Right. As you heard, we do receive research grant support from Alcon, but has no relevance on this presentation. And this is a case that I'm going to present to you, but I just want to recap some of the pearls that we learned from many stalwarts like Dr. Osher and many others. We need to make sure that hydraulic rupture, which takes place in a posterior polar cataract with intact capsule, is not happening because of the wrong fluid injection, create a cushion, and we find that phampton delineation is a good trick. Counseling the patient and the family remains very important. So this is a patient who came to us with bilateral pre-existing posterior capsule defect behind the posterior polar cataract. The left eye had a total white cataract. So we decided to operate the right eye first so that we understand, and you can see that there is a open capsule here. And that's the advantage of these things. You perhaps could pick up in a UBM, but this is more precise. So this is the patient's on a table. You can see the pre-existing defect here. And now my aim would be to prevent vitreous prolapse from through the tear into the anterior chamber so that I don't disturb it. So that's my thing on my mind. Notice the parameters on the right side, 20 millimeter of mercury IOP, which can go to 30 if necessary, but the flow rate is 18 cc per minute, and the vacuum is about 100. I'm using more of energy and then debulking these tires or the delineated material that we have, and it's very easy to bring it to the phaco tip because they're laser cut, and one ring after another will come to the phaco tip. So now we need to make sure that when you withdraw, you inject, and we inject viscoat because in case if there is an open capsule like this, and if the vitreous gets mixed up with the methyl cellulose, it is more inflammatory. So viscoat is something I would recommend. And this is the thing. What we are doing is that we are establishing a communication between the anterior chamber and the critical compartment here by detaching these epinucleus in 2-3 clock hours. Once you do that, there won't be any buildup of hydraulic pressure in that region. So this is a trick which is very important. Do not aspirate the entire epinucleus just like that. Just create communication so that the fluid goes around that gap, through the gap. And now I'm putting irrigation behind that epinucleus and trying to remove that with a very gentle aspiration flow rate, 16 cc. My IOP has gone up now to 50 to make sure that the fluid is pressurizing the open capsule. So far, we have not disturbed the vitreous, and it seems that we are fortunate, and we did prevent what we wanted to, vitreous prolapsing. And now we need to make sure that we fixate the IOL at the right time, right place. So then the consideration would be 3-piece IOL, haptics going underneath the iris in the ciliary sulcus in front of the anterior capsule, and then I'm not dialing it, but I'm using the McPherson forceps to put that trailing haptic underneath the iris. Now I'm nudging the lens in such a way, pressing it towards the retina, that the entire optic goes posterior to the posterior pre-existing tear and also the anterior capsule. So both of these are holding the lens. I'm capturing through both posterior capsule and the anterior capsule, and the lens is quite stable. We need to suture this lens because this was almost 4 millimeter incision, 3.5 plus. I always make sure that vitreous is not there. I'm using vitrectomy here to remove thing because we already had it out thinking that we'll need it. We never needed to use it, but I am justifying its presence on the trolley. So that's how it is, and at the end, after a few days, this is how it looked. And if you monitor with the UBM, with the retinal colleagues, not only the macula but peripheral retina, it's very critical that we do that. Quite often, actually, in this modern time for last few years, we have a retinal colleague working with it, and you would be very happy, Dr. Dadani, that your role has always been there, but much more now. So we warn him, and he's around. He's downstairs in the other floor, and he said, I'll come up any time. So we really co-manage it. But this is something I could do it, but I would recommend, if you have a posterior polar and particular things like this, always keep the retinal colleagues there. You will need it. So this is once again a femto delineation situation, but not delineated because the lens X will not go through the opaque material. So at least we got the right size, and that right size would be 4.8 maximum, because we need that capsule capturing the IOL. So not very big. So with the lens laser technology, we can do that. But here, we had to do what we find very useful, described many, many years ago, where you create a space and create a mechanical cushion effect by injecting fluid there. With this kind of a firm cataract, you won't be able to penetrate very deep, but that's sufficient enough. Thin epinucleus cushion is enough to protect that pre-existing defect. And then notice the IOP20, IOP30. Flow rate is around 16 to 18, and vacuum minimal, 100 or so, but more energy. So I'm debulking rather than trying to chop it. And then once I go to the peripheral, I will use the chop principle, 300 vacuum at the most, which I would have otherwise used 500 or so, but as minimal as possible. Try to use the second eye to position so that you don't need to really aspirate, because I'm looking at the posterior capsule tear and the antivitreous trying to come in there. Notice, in spite of the tear, I'm trying to bring that very slowly, and my bevel is either sideways or sometimes facing the posterior capsule. I'm conscious of the endothelium. IOP is still 20, but it can go up now that there is some space created. But very slowly, 16 cc or 18 cc flow rate, 300 around vacuum, sufficient energy, and using the left hand and the Ozil technology and keeping it sideways, less material will keep coming. We want to avoid rotation of the nucleus, because in an open capsule, it can further enlarge or bring the vitreous. So I brought it out in the antechamber, and I'm trying to remove it very gently, with the bevel down. You can see that the bevel is facing capsule. That's because the chamber is very stable and the right flow rate. Once again, injecting visco. Notice the pupil has gone down. So we injected intracameral adrenaline, and that's why you see now the pupil dilated. Remember, you can use adrenaline in between if the pupil dilates, if the pupil constricts, because of the mechanical stimulation of the lens material coming to the near to the pupil. Now, bimanual, of course, is the way to go. And when you swap these, inject viscoat again. So far, we have not disturbed the vitreous. So now I'm injecting viscoat because I want to swap my irrigation and aspiration. And now I'm a little bit nervous. I'm not sure whether there is a vitreous strand coming. And I believe that there is some vitreous there. I'm not very sure, so I'm going very slowly, and I don't think you will be able to see on the video, but there is some vitreous strand at this point now at this stage. So we decided that we need to treat it. We cannot just leave there. So as you saw Dr. Samresh doing, we prefer pars plana entry for the vitrectomy, but irrigation we keep it in the antechamber. I'm not sure whether we should be doing the total pars plana. My retinal colleague would straight away do that, and sometimes he ends up total vitrectomy, which is a great stuff. Anyway, so here as a cataract surgeon, I'm doing this sufficient anti-vitrectomy through the pars plana, and then as we did in the other eye, previous eye, I'm putting these haptics underneath the ciliary sulcus and using the folding forceps. I didn't use the cartridge because I wanted to make sure that with the open capsule, sometimes the haptics sort of swipes and touches the vitreous face. So I had a control with this kind of forceps. These are Burato forceps. I've used it before some of you were born, so I'm used to this forceps. This, once again, capturing optic, pushing it posteriorly and nudging it in such a way that this tear, posterior capsule and the anticapsule, both are anterior to the optic, and the IOL is very stable, needs to suture, make sure that there is no triamcinolone, and that's it. So I think go slow motion technique, make sure you create a cushion, and remember not to be very aggressive with the flow rate. It is the flow rate which really attracts the capsule, iris, and vitreous. So thank you so much for patient hearing.